This is Matt Kruger from Denver, Colorado. Here I'm going to start a new series called Towards Zero Complications, where we'll show cases that are interesting or unique or routine cases to show how we can reduce our complication rate towards zero, or less than 1 in 1,000 cases for a vitrectomy. In this case, we have a 90-year-old woman who was referred by a retina specialist who has been treating macular degeneration, and the view is now too poor to treat her macular degeneration. She has a 3 to 4 plus nuclear sclerotic cataract and hand motion vision. Here we'll start off by making a paracentesis. We'll use a cut Weck so we avoid subconjunctival hemorrhages so the eye looks good the next day. The patient may not notice the result of the cornea and the lens, but what they will notice in the mirror is whether or not they have any subconjunctival hemorrhage, and so avoiding that's always nice to have. Next we'll start out with some lidocaine, which we already did, to numb the eyes. This case is under topical. As you can see, the patient can't fixate well, and we're talking here called vocal local to see if she can see the light. We'll turn the light off and turn it back on just so she can appreciate the difference between the light being on and off. Next we'll stain with trypan blue. We'll stain for about 30 seconds, which I edited here in the interest of time so that we can see the capsule very nice. I like to get a deep stain in these cases so that it's good during the rhexis and during the actual phaco, as it's nice to be able to see the edge of the capsule while you're doing the nuclear disassembly. It's not just important for the rhexis, but also for the nuclear disassembly in these denser cases that can last longer. And finally, we'll fill the anterior chamber with viscoat fully to get the capsule flat, as well as to pressurize the eye. That often helps diminish the light reflex as well, bringing up the IOP so the patient can fixate better. Next, we'll use a very sharp mani blade. I think one of the interesting things for safety is also having very sharp blades. You don't want to be struggling to get the wound made, to have a complication, to make it too long, or to have the patient move while you're doing it. Next, we'll start with a cystotome here to start the rhexis. It's a small, short one from Alcon, which is a great cystotome. You can see the capsule is quite elastic here. We actually have a hard time puncturing down, but we finally do after a little bit of effort, and then we'll raise a flap. Now, this patient is 90 years old on multiple blood thinners. Otherwise, I would have thought about doing a block for her, but due to safety, I think topical is still better. Now, we want to get a big rhexis here because this is a dense lens, and it's not really a refractive case, so getting a 6mm rhexis would be nice. A 5mm to keep the lens in its best ELP is not critical here. But because the patient has a hard time fixating and has been moving a little bit earlier in the case, I'm going to start the rhexis out a little bit small. That way, there's no risk of tear out if she were to move suddenly, or if there was a tear out, we could rescue it before it gets to the iris plane. And so we'll start out making about a 4.5 to 5mm rhexis like we might do for our usual case. Now, one thing we like to do is refill with viscoelastic, because the longer you're in the eye, the more that it burps out. But I want to do multiple regraspings here during the rhexis so that I can control it well. We just don't want this to tear out, as we're going to have problems getting the lens out safely. So once we have refilled the anterior chamber so that it's well inflated, we'll just slowly go around with multiple regrasps. And we want to get this pretty close out towards the pupil so that we can really get a nice rhexis size so that it's easy to chop and easy to remove. The problem with working through a 5mm rhexis is that you're going to have a hard time pulling out the first pieces with our chop technique, which we like to use, as I consider that's probably the safest technique. Here you'll see we're just coming around. Want to make sure that the anterior chamber stays formed. And so far so good, she's not moving too much, and so we'll just try to make this a little bit bigger, coming around, doing a spiral rhexis. And since I do the chopping towards the nasal side or away from me, we'll extend the rhexis there just a little bit more so that it's not in the way at all as we pass the chopper around. And then we'll just pull this out so that we have a good view. Now we can see we have a nice circular centered on the reflex Capsulorhexis, and we'll do a little bit of hydrodissection. Now this seems almost like a bit of a white cataract. The nucleus cortex seems that it's very soft, and so we don't need to do a whole lot of manipulation here with hydrodissection. Now we're ready to start the phaco. As you can see, this is a dense lens, and we'll change the lighting here a little bit. We had just the center lights on before, but I think you can see better by having the peripheral lights on as well. This is with the Lumera. So if you've watched our previous chopping videos, you'll see that we typically just do the same thing, just minor modifications for these denser lenses. What are those modifications? We'll still get rid of the anterior epinucleus, and you know that this is going to be a case that horizontal chop is safe on because there is a little bit of peripheral epinucleus that we can shave down, and there's room to pass our chopper. Now, typically we like to make a short little pothole about 1/3 into the lens, But when you have a dense lens like this, the key thing for getting it chopped in half easily is to get down about 2/3 depth. And so you'll see here, we'll spend some time making our little pothole underneath the subincisional area here, but we'll go pretty deep so that we're about 2 to 3 millimeters down into the nucleus, knowing that we're well past half, if not 2/3. And then we'll do our typical technique where we'll leave the phaco tip in the pothole and we'll pass out our chopper. We're touching the epinucleus while we do this so that we know it's below the capsule. And you can see the first time it doesn't go. If it's a dense lens, a truly dense lens, it will not chop on the first time. Typically you got to do 2 or 3 times. But the second time, it gets a little bit deeper, and we're able to crack this more or less in half. It doesn't go all the way across, but to get the first piece out, we don't need it. We just need it to go about 2/3 the way across, or a little more than half. Then we'll do the same thing. We'll pass it out over, and then we'll separate this piece. Now, we probably have a little tag here right in the center, which is going to be hard to pull out the first piece. One technique I like to do is to use viscoelastic to do a little bit of viscodissection between the pieces. It also protects the endothelium and helps protect the posterior capsule. Now you can see here we got a pretty good separation and we protected the posterior capsule. And one of the best ways to get out that first piece without much effort is to go in through the main incision without the phaco tip. Here I'm just going to rotate the nucleus a little bit and then make sure that piece is freed up, and then we'll just go right behind it and pull it up into the center. And then I'll rotate a little bit so we're set up for our next chop, as it's much easier to rotate with the viscoelastic filled environment here with the chopper through the main incision. And this helps prepare the next piece for removal. So now we got the first piece teed up, and the second piece has been moved around into position for further chopping. Now here we'll switch to the Drysdale just to manipulate the lens. And also if the patient moves suddenly, it's nice to have an instrument that will just slip out of the eye instead of the chopper, which can get stuck and cause a complication if the patient really moves or jerks their eye around. So we got the first piece out here now. Now we're left with this large heminuclei, and we need to chop this some more. So we'll go back to the same technique. We use the chopper without vacuum just to stabilize the nucleus. Here you got the chopper coming in. The phaco tip will stabilize. The chopper goes around. We go through the epinucleus to make sure we're below the capsule. And then we got a nice little chop piece, and it's pretty easy to chop these pieces once it's already in half. And then it's a matter of just bringing up the next piece. It's nice to just go behind it and lift it out. This way, the phaco tip never leaves the central area. It's extremely safe, and there's really no risk for posterior capsular rupture, which is the beauty of this technique. I really like this technique because it can be used for the softest of lenses and up to very hard lenses. I will switch to a vertical chopper if there is absolutely zero epinucleus, but typically that's rare to find a case in the States that has zero epinucleus. Typically there's always a hint of epinucleus on these brunescent cataracts. Here we just keep feeding the pieces into the phaco tip with the chopper here. As I've said, this is a great technique to not need any vacuum or go into the bag to pull the pieces out. Now again, since we have this dense lens and we're using a lot of phaco energy, we'll go back in. We still have our tube of viscoelastic to refill the capsule, and this will help protect the capsule from further any damage from the instruments, either the phaco tip or the chopper. And like I said, it's nice to spin. This is very low risk to the zonules to spin it around through the main incision, which can be easily done while we're out of the eye using the viscoelastic as it is. And we'll just put a little more visco in there so that we don't have to worry about the capsule being in the way. Now we still have a large piece of the lens here. So again, just like before, we'll stabilize the lens with the phaco tip. This is again, no vacuum. You won't see any vacuum. And this helps us get the final pieces made. And basically we're almost finished with this case. Now we just tee that up. And like I said, I like to switch to the Drysdale just for safety, as it's easier to manipulate the pieces around, especially if they come towards the main incision through the fluidics of the procedure. And now we're just using our phaco, just going slow, being gentle. Again, we don't want to rush this. Nothing takes more time than a complication to deal with or a vitrectomy. And so we're not trying to rush this case or speed through it. We just want a very good outcome for the patient. And we'll just keep feeding these pieces in. Here we'll reach across and see if we can pull this piece out. Now this typically be under chop and not under quadrant removal. We don't want any phaco involved, just some vacuum to pull that towards us to do that safely. And here basically the pieces of the nucleus have been removed and we just have a little bit of epinucleus. Now I'm worried that the capsule could be floppy, so we're going to switch over to the polymer tip IA. We could try and remove those pieces with the phaco tip, but generally these look pretty soft to me, and I think it's safer always to switch to the IA as soon as you can. It may take a little while longer, but again, there's almost zero chance of having a complication or rupturing the posterior capsule with the polymer tip. It's a very safe tip, and I use this for all my cases. Here we just have some nuclear chips that have come around, and we just feed those into the IA port with the Drysdale to break them up. Here we're just getting the last bits of the epinucleus out, and then we're left with the cortex. Again, this is the part of the case where if we can breathe a sigh of relief, we've gotten most of it out, but we still need to get a nice cleanup of the cortex to get the patient a nice result, especially here so the retina specialist can treat her. We don't want her to have any PCO. Here you can see there's still some viscoelastic filling the capsule, which has been very nice for keeping the capsule away from the instruments, especially the phaco tip. And we'll just keep going around polishing. Again, we've got a little piece. One problem with chopping is that you do get some small pieces that have to be dealt with, and again, we don't want to see that in the anterior chamber the next day, so we'll be careful to get those out. And we'll just keep sweeping around very gently. Now, if there are some cortical remnants, especially subincisionally, that are there, it's always safer to put the lens in first and see you get some spidering of the capsule. We don't want to break this capsule. So here we'll just go around the rest of the anterior chamber, getting rid of these last little pieces. And you can see there's still little pieces subincisionally, but we can get these later once the lens is in there protecting the posterior capsule. This is Provis going into the capsule just to fill it up, and then we're ready to put the lens in. Here we'll be putting in the Invista lens. This lens is nice because it's a little bit stiffer than the ZC Boo or the Alcon lens, and it's nice for these larger incisions or larger capsule sizes, as there's no risk of prolapse typically once the lens is in the bag, even though the Rexis here is about 6 millimeter and the optic of the lens is about 6 millimeters. Now we use the Shepherd polisher just to go around and get rid of the capsule remnants or the cortical remnants underneath the capsule here, so that we don't have any of that causing phimosis. Another concern with these dense cataracts in an elderly patient with retinal treatments would be capsular phimosis. So once that's gone, we can go back in and go ahead with the IA. We always go under the lens to get rid of the viscoelastic. There's been some studies showing that there's lower rates of endophthalmitis when there's cleanup of the viscoelastic, which makes sense as that could trap some bacteria. And then we're just cleaning up now. I like to go behind the lens, in front of the lens, and we'll try and get any last bit of subincisional cortex there now that it's very safe to remove that. Now we can always easily do a YAG later, and so we're not going to be aggressive about polishing this floppy posterior capsule. As you can see when we come out, there's no prolapse of the lens, showing how nice the Invista stays centered towards the end. And then now we've got to seal up the wounds. Now this is a 2.4 millimeter incision and a 1 millimeter incision. They seal up nicely with the hydration there. Still see some pieces, so we'll just go back in and just get these last little bits out. But again, we don't want to be too aggressive, as we don't want to have a last-minute complication here by engaging the capsule. Once all the viscoelastic has been removed, we'll go ahead and reseal. This is just with BSS into the incisions. Overall, this is looking pretty good. The chamber is forming nicely. Once the side port's sealed up, I always like to check with the Wexel just to make sure that there's no leakage. You can see the wounds leaking if there is some leakage. And once that's done, we get the eye to the right pressure, and then we'll put in our intracameral antibiotic. We use the moxifloxacin under Steve Arshinoff's protocol and have had zero endophthalmitis over the past 5 years using this technique. Once the pressure is at the right pressure and the chamber is formed, we'll finish this case. Overall, we're happy with the result. If you have any questions or comments, please let me know. Thank you.